The patient is positioned prone to provide the surgeon with adequate exposure to the posterior bony anatomy of the spine. As part of preoperative planning, the surgeon will determine the proper access point for the procedure by drawing a line on the patient along the midline of the spine and 2 to 4 centimeters lateral of the midline with the assistance of fluoroscopic imaging. A skin incision and fascia release along the marked incision line is made. The dilation process begins with the 2.8 mm smooth Steinmann pin docked to the bony anatomy. Position and trajectory are verified with fluoroscopic imaging. Once position and trajectory are confirmed, sequential dilation is performed over the Steinmann pin. The first stage dilator will be placed over the Steinmann pin, and after proper positioning, the Steinmann pin is removed. A gentle sweeping of the first stage dilator is performed to aid in removing soft tissue from the bony anatomy. Sequential dilation of the surgical incision continues until all 5 dilators are docked to bony anatomy. A gentle sweep at each stage of the dilation process can be performed to further aid in removing soft tissue from the bony anatomy. The dilators are labeled with centimeter depth markings to allow the physician to determine the blade length necessary to achieve the proper exposure for the procedure. In preparation for the surgical procedure, the field posts and access arms must be set up on the OR table. These articulating arms will provide stability and rigidity to the Accuvision frame while allowing for intraoperative repositioning. The Accuvision frame is prepared with the initial cephalad and caudal retraction blades. Blade length is determined from the depth markings on the sequential dilators. The blades are attached to the retractor arms with the curved portion facing the center of the frame. When secured into the dovetail lock of the frame, an audible click is heard. With the blades in place, the frame is guided over the sequential dilators and docked onto the spine. Use fluoroscopic imaging to verify position. The frame can be placed with the open side facing medial or lateral to the surgical incision, depending on surgical preference. Upon verification of positioning, the frame is secured into position by attaching the distal ends of the articulating arm to the posts of the frame. The sequential dilators are now removed from the patient. Initial cephalad caudal distraction is achieved by utilizing the hex wrench placed on the center hex nut and turning it in a clockwise rotation until the proper amount of exposure is provided. It may be necessary to extend the skin incision and fascia release to ease pressure against the blades and allow for additional visualization into the surgical site. Additional retraction of soft tissue in the surgical site can be achieved by angulating out the distal end of the individual blade. Place the hex wrench on the hex nut of the retractor arm and turn in a clockwise rotation. The lateral retractor arms are secured onto the dovetail connections at the distal ends of the retractor frame. In the non-extended position, the retractor arm will fit into the surgical site. Arm adjustments are made with the retractor wrench, placing it on the hex nut of the retractor arm and turning in a counterclockwise rotation. Additional retraction of soft tissue in the surgical site can be achieved by angulating out the distal end of the individual blade. Place the hex wrench on the hex nut of the retractor arm and turn in a clockwise rotation. An additional retractor arm module with the desired length blade can be secured onto the opposite dovetail connection on the retractor frame. When complete, the assembled frame provides 4 points of retraction, allowing generous visualization to perform the indicated procedure. The pivot point construction of the retractor frame allows for additional variability. Airplane angulation of the inner frame provides even greater visualization without having to destabilize the operative setup or blade positionings. This airplane angulation provides up to 45 degrees of variability, helping to provide additional exposure to the surgical site. Upon completion of the surgical procedure, the retractor frame is removed from the surgical site. Any airplane angulation of the frame is reduced to a neutral position. Shim extension, distraction, and angulation of the medial and lateral retractor arms is reduced, and the retractor arms are removed from the surgical site. Cephalad caudal distraction is reduced, and any distal angulation of the individual blades is reduced. The articulating arms are unlocked at the field post and removed from the posts of the retractor frame. The frame is removed from the surgical site, and closure of the wound is performed according to the standard of care.